Good afternoon, everyone. I am Dr. Sabaratnam. I am an assistant professor and consultant of Department of Endocrine Surgery from SGPGI Lucknow. I thank Professor Rajshekhar Mohan and Dr. Jnanaguru Swami sir for this opportunity. I am sorry that I am not able to be present in person. I am today dealing with benign breast disease and mastalgia, what a rural surgeon should know. Benign breast disease includes all non-malignant conditions. They do not convey increased risk of malignancy. Most commonly misdiagnosed and misunderstood entity. Interdisciplinary collaborative model of care is needed for successful management. And before we go into mastalgia, I will present a case, 25-year-old female patient with cyclical mastalgia since 1 year, mild throbbing pain during the menstrual period, no history of nipple discharge, no previous surgeries, no history of diabetes or hypertension, with normal menstrual cycles, married with no children, and similar history seen in mother and grandmother. And she went to many physicians. These are different prescriptions of antibiotics, and you can see this patient with her mother and grandmother, husband and father in my chamber. So for a surgeon, it's a very small problem. For a patient, it's very big. That's what I want to convey with this slide. And these are all not needed. Somebody has done all these tests outside, including calcium. TSH and prolactin are relevant. TSH is 2.83, prolactin is 12. And ultrasound of the breast was essentially normal. And sonomammography, they are repeated again. And what is mastalgia? Mastalgia is present in 70% of women in their lifetime, and 5% of Asian women suffer. We have to differentiate this from premenstrual syndrome. And coming to the classification and description of mastalgia, there are three types of mastalgia. One is cyclical mastalgia, one is non-cyclical mastalgia, and chest wall pain. This is very, very important. Cyclical mastalgia is pronounced pattern, pain experienced around the luteal phase of menstrual cycle, associated with ovulatory cycles, more common in premenopausal women, often bilateral, and described as sharp, shooting, stabbing, heavy aching during the periods. Non-cyclical, no pattern, no association with menstrual events, tend to be well localized, subareolar, medial, very difficult to treat. Chest wall pain has no pattern, and we have to rule out costochondritis or teeth syndrome. It is always musculoskeletal in origin. And coming to mastalgia, etiology is not very well understood. Hormonal effects of estrogen, progesterone and prolactin, many studies have done, but some studies say there is an imbalance. Some studies say that there is a hyperresponsiveness of prolactin, abnormalities of lipid metabolism. In luteal phase, there is a higher estrogen-progesterone ratio, which in turn leads to fluid retention and width of the duct being increased. And coming to this query, which the patient and the family will ask you, whether mastalgia means increased risk of breast cancer. It is a big no, rarely a symptom of breast cancer. 5 to 18% of advanced carcinoma of breast can have pain. And stress is an etiological factor for mastalgia. People with anxiety and depression can have mastalgia. Reassurance from the part of a surgeon is a must. So education of why there is pain and reassurance should be a part of integral management of mastalgia and first line treatment. And whether well supporting brassiere improves pain, 75 to 85% improvement is there. 2 prospective studies support this. So what is the recommendation is the use of a well-fitting bra provides good support and should be considered for relief of cyclical and non-cyclical mastalgia. And coming to evening Primrose Oil, we use it as the first line of management, gamma-linolenic acid. It restores abnormal fatty acid profile, decreases the sensitivity of breast epithelium to steroid hormones. 3 randomized control studies showed no efficacy, 2 studies showed efficacy. But still, in our setup, we use it for treatment of cyclical mastalgia. And coming to Evion or vitamin E, 3 randomized control trial, they said no better than placebo, but Indian guidelines advocate this. So we use Trimosa and as well as Evion as the first line. If the patient doesn't respond, we go to the second line. Coming to reduction of caffeine and theophylline intake, the 80% reduction of pain is there when there is a complete stoppage of methylxanthine. So, but the randomized control trial studies do not support this. But some studies, recent studies say that there is a good efficacy if you ask the patient to abstain from coffee and tea. And hormonal replacement therapy increases the intensity of pain. So once you stop these contraceptives, then the pain disappears, and we can ask the couple to have alternative birth control. And the role of dietary fat, isoflavones, flaxseed, herbs are all questionable. And there are 2 studies, randomized controlled trials, where the patient was given 10 mg of Tamoxifen, and there was a 94% improvement in cyclical mastalgia and 56% in the non-cyclical group. So many of the guidelines say if your first line group fails, then you can start Tamoxifen as second line, but some guidelines also recommend Tamoxifen as the first line. The drugs and the side effects are given. Tamoxifen 10 mg OD is the usual dose given. Hot flashes, menstrual irregularities, and evening Primrose Oil 3 grams is the recommended dose. You can have soft stools and headache. Bromocriptine second line, nausea, dizziness, headache, postural hypotension. Danazol can cause amenorrhea, menstrual irregularity, weight gain, hirsutism, deepening of voice, and hot flashes. So one randomized control trial compared Tamoxifen with placebo with Danazol, and you can see 72% reduction of pain for mastalgia was there, successful reduction with Tamoxifen. So coming to the algorithm, breast pain, we have to take a good history and a physical examination, mild cyclical mastalgia, education and reassurance. If there is a physical finding, then ultrasound, and then we have to proceed. If it is patient less than 35 years of age, ultrasonography is recommended. More than 35 years of age, mammography is recommended. Again, reassurance is most important. You give symptomatic pain relief, firm support bra, and then analgesics with the NSAIDs should do. If there is a cyclical mastalgia not responding, then we have to ask the patient to charge the pain, and then we usually start on evening Primrose Oil and Evion as the first line. If the patient is on hormonal replacement therapy, ask her to stop that. Then we have to understand that the cyclical mastalgia with the evening Primrose Oil and vitamin E for 3 months, there will be good improvement. If it is a non-cyclical mastalgia, then we have to see whether we have to go for second line or not. First line has to be tried. If it is not functioning, then second line. So if evening Primrose Oil was successful, then we can ask the patient to take only during the luteal phase of the menstrual cycle. And then if it is a childbearing woman, we have to counsel, and if the patient is on hormonal contraception, we have to change to some other ways of contraception, and the pain will settle. Most important thing is counseling, and if the first line drugs fail, then we can go for Tamoxifen or Danazol. The most important part of treatment of a mastalgia in any setting is to counsel the woman that she is not predisposed to cancer. And even the second line phase, then we can consider using bromocriptine, which is the third line. That is most important. So we see a lot of patients in our OPD, and most of the patients belong to cyclical mastalgia, and most of the benign breast diseases like fibroadenoma are operated in OPD setting. That will be reflective, but many we see around 500 patients of mastalgia in a year. And I again want to convey this message. We have to counsel the patient that it is not a malignant disease. it is curable, and dietary modification in the form of stopping coffee, tea, chocolate, and with the first line of evening Primrose Oil, 1 gram 3 times a day, with Evion 200 milligram in the night will cure many of your patients. Thank you, and hope we conduct the Association of Rural Surgeons of India conference in Lucknow, and hope to see you in Lucknow soon. Thank you.